Welcome. Hi, thanks for the opportunity to talk this morning. Sorry. In the next half an hour or so, I'm just going to outline briefly what Mendelian randomisation is, why it might be useful, and give some real examples in the field of cardiovascular disease which are making a difference at the moment. Okay, so why do we need Mendelian randomisation? Well, I mean, if you search the literature, you can find an awful lot of false claims for environmental risk factors and their effects on disease, and this is one such example. So in the New York Times in the early 90s, it was claimed that taking vitamin E would greatly reduce your heart disease risk. And you can see all sorts of claims like this in the press every day based on epidemiology findings. And of course, people in the States read these papers, they started taking vitamins, as you would if you thought it was going to reduce your heart disease risk. And you can see this, that the intake of, in particular, vitamin E, but also multivitamins and vitamin C, which was also claimed to reduce heart disease risk at the time, increased dramatically. If you look at the study, so the newspaper headline was based on a cohort study, and you can see quite clearly that the risk of heart disease decreased. The risk of heart disease actually decreased with duration of vitamin E supplement use. And of course, people who were selling vitamins loved these studies because obviously, you know, it increases the uptake of vitamins, and they made claims such as this, which reinforced the kind of health message that, the average American lifespan has increased nearly 3 years over the last 2 decades. We've been selling vitamins at a discount since 1977. So, of course, the vitamin industry loved these studies. The problem was that if you look, obviously there are other cohort studies around the same time and others that followed on afterwards. And if you looked at the cohort studies, you found this reduced coronary heart disease risk with vitamin E supplement use. However, when people went on to design randomized controlled trials, what they found was that giving people vitamin E supplements in a trial had absolutely no effect on their coronary heart disease risk, which is not what you would expect if vitamin E really is reducing your heart disease risk. You could argue that people in the trial weren't taking the vitamins for long enough, or they weren't taking the right dose, or maybe something, you know, there was some other problem with the trials. But I think the most likely explanation is that there were flaws in the observational studies. And Debbie Lawler from my department went on to look at vitamin E use in the British Women's Heart and Health Study. And what she wanted to know was what other risk factors are associated with vitamin E levels. So people who are taking lots of vitamin E, what does their risk profile look like? And what she found was that those people who were taking lots of vitamin E had tended to have lower childhood socioeconomic status. They were more likely to be from a manual social class. They had less car access. They tended to smoke. They were more likely to take daily alcohol. By day, I mean small amounts of alcohol daily. They were more likely to exercise. They were less likely to be obese. So there was all sorts of risk factors in there which could have explained this observed association between vitamin E and heart disease risk. So the observed association could be due to any one of these factors, which was strongly correlated with vitamin E intake. So where does Mendelian randomization come in? Well, Mendelian randomization is really about using genes, but not for for the sake of looking at genes. It's really because obviously we can't modify our genetic makeup. It's really using genes which interact with the environment, which influence an environmental risk factor, to tell you something about how you can modify your disease risk by modifying that environmental risk factor. And the reason that you would want to use genes rather than just asking people, you know, what's your vitamin E intake or how much alcohol do you drink per day, is that lifestyle factors are confounded. But if you could find a gene which influenced, say, vitamin E levels, circulating vitamin E levels, it is unlikely to be confounded by all the other environmental factors that I showed you. So a gene which modified vitamin E levels in the blood is unlikely to be associated with how, you know, whether you've got a car or not. So, so what Mendelian randomization does is use genes as a proxy for measuring an environmental risk factor. And hopefully this will become clearer when I show a couple of examples. Okay, so this is how it works then. This is a very, this is not the type of common polymorphisms that we tend to use in Mendelian randomization, but it illustrates the point quite nicely. This is a mum who carries an X gene which causes haemophilia. Okay, so the chance of any of her children inheriting this this haemophilia causing gene is 50% because she's got two X chromosomes, and each child will inherit one of those chromosomes. So it's the same for any genetic variant that you could think of. The chance that your child will inherit it is random, and it's 50%. That means that it's random, and it's unlikely, unlike environmental factors, it is unlikely to be associated with other lifestyle factors. And George Davies Smith, who sort of founded this idea of Mendelian randomization and wrote an awful lot on this, did this quite nice study where he showed that if you took 93 phenotypes, and by phenotypes I mean things that you can measure in people, so these could be lifestyle factors or biomarkers or anything, really. If you took 93 of these and you took 23 genetic variants and you did all pairwise combinations of phenotype, 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 genotype, and genotype, genotype that you could possibly do, what you saw was that there was a huge amount of clustering of phenotypes. So many of the phenotype-phenotype associations were significant. The P is less than 0.01 levels. So you get 43% of all associations between phenotypes and phenotypes were significant versus, you'd expect 1% by chance. So that was a massive clustering of environmental factors. But if you do the same test for genotypes, phenotypes, and genotype, you only get the amount of significant associations that you would expect by chance. So what that shows is that genotypes are not associated with these factors. If you see associations, it's probably a chance finding on the whole. So how does Mendelian randomization work then? Well, you have obviously a modifiable exposure, which you might be interested in. You might want to know, if I modify that, will that reduce my heart disease risk? You might have a lot of epidemiological studies which suggest that this is associated with this. The problem you have is confounding explaining this association. So is it some other factor? So if you're looking at C-reactive protein, this is associated with BMI, for example. So is it the C-reactive protein that's causing heart disease risk, or is it something else that's associated with C-reactive protein? Or could this association be explained by reverse causation? And what I mean by this is early heart disease affecting your C-reactive protein levels. So maybe there's an immune response which increases C-reactive protein. And so you see the two associated. But it doesn't mean that C-reactive protein is causing heart disease. So it's often impossible to exclude these explanations. But if you had an instrumental variable, a genetic variant, which affected C-reactive protein levels but wasn't associated with confounders, and it couldn't be influenced by reverse causation because your heart disease risk cannot change your genetic makeup, then you could look at the association between this genetic variant, which is affecting C-reactive protein levels, and see whether that is associated with heart disease risk. If C-reactive protein truly causes heart disease, then a genetic variant which increases your C-reactive protein levels should increase your heart disease risk. And George and colleagues, George Davies-Smith and colleagues, actually did this experiment, and what they found was that there was absolutely no evidence that C-reactive protein increased heart disease risk. They found a SNP which was strongly associated with levels. When they looked at that SNP in relation to heart disease risk, it wasn't associated with heart disease risk. So I'm just going to briefly talk about another study which we did, which was to look at whether alcohol influences blood pressure, it should say the risk of high blood pressure. Obviously, everyone has blood pressure. And the reason for doing this study was that there was an awful lot of epidemiological studies which suggested that if you had a little bit of alcohol each day, that would be good for your blood pressure. It would actually lower your blood pressure. And this is a claim in the medical news that this was the case. The nice thing about alcohol is that we have a very nice genetic variant which affects alcohol intake levels. But this variant is only present in certain Asian populations. So in Chinese and Japanese populations, it's very prevalent, but not in European populations. And what this variant is in this gene, which metabolizes acetaldehyde. So alcohol's ingested as ethanol. This is broken down to acetaldehyde. Acetaldehyde is actually quite poisonous. So this is further metabolized by ALDH into acetic acid, and that's excreted in the urine. Now, there's a common genetic variant in Chinese and Japanese populations in this gene, which means that people cannot metabolize this pathway. And what that leads to is a buildup of acetaldehyde. The symptoms associated with that are, being sick, having a severe headache. Basically, these people cannot tolerate alcohol, so they tend not to drink. And if you look in studies by genotype, so these are the people that can metabolize alcohol. These are heterozygotes that can metabolize it a little bit, and these are people that cannot metabolize acetaldehyde. What you see in men is that alcohol intake decreases according to genotype quite dramatically. So these people are having 50 grams a day on average. These people are having nothing. So it's quite a striking difference. In women, you don't see any effect of genotype on alcohol intake because they tend not to drink anyway for cultural reasons. So what we did was we took several cohort studies which had been published, which had this genotype and they had blood pressure measured, and we looked at the effect of genotype on blood pressure. So we compared people with the 2-2 genotype, which meant they didn't drink, to those with the 1-1 genotype, which meant they drank sort of normal levels. And what we found was that people with the 2-2 genotype had a much lower blood pressure than those with the 1-1 genotype. In fact, it was 7.44 millimeters of mercury less than those with the 1-1 genotype, which, as far as I know, this is the biggest genetic effect of on blood pressure of any gene. And if you look at GWAS studies in these populations, in Chinese and Japanese populations, not surprisingly, this genotype comes out as the biggest hit for blood pressure. So, and what you find in women is no effect of the genotype on blood pressure. So that kind of assures us that the effect is not really a direct effect of the gene on blood pressure, but more an interaction with alcohol intake. So this is the difference in blood pressure per 1 gram of alcohol per day. And we calculated this based on the effect of the gene on alcohol intake and then the effect of the gene on blood pressure. So you can do this with Mendelian randomization. Okay, so I hopefully I've illustrated that Mendelian randomization can be useful and how you might use it. And I'm just going to briefly talk about some limitations, because you might have heard of some of these, and some solutions to these limitations as well. So the problem is that Mendelian randomization studies often have low power. And the reason for this is that you don't often get big effects of the genotype on the exposure. So the alcohol story was quite an extreme example. But often, a lot of the genes that you're using have very small effects on the exposure. So in order to detect an effect of that exposure on disease using the gene, you need huge numbers. The solution to that is collaborations, I guess, and meta-analysis. And this is quite a nice recent example where there was a collaboration between 82 studies. They carried out a meta-analysis. They had 125,000 participants. So this is not a small study. They looked at genes in the interleukin-6 receptor pathway, and they found that this that SNPs in this pathway were associated with coronary heart disease, showing strong evidence that this pathway is causally related to heart disease risk. So the solution is just get more samples, I guess. But another solution is that you can often use multiple genetic loci. So if you have lots of SNPs which have small effects on, say, LDL cholesterol, in some cases you can add those SNPs together to get a kind of LDL score. And what you find when you do that is that the score explains maybe 10% of the variance rather than each individual SNP explaining 0.5%. So that can be another way of increasing your power. Another limitation is that there are some instances where you can have confounding using genetic studies. One is population stratification, which I'm sure if you're doing any genetics you know about. The solution to that nowadays is if you have GWAS data on your samples, you generally are able to adjust for population stratification using principal components which define underlying population structure. Another limitation is pleiotropy. So your gene might be related to your exposure, but it could have another effect. It could affect your outcome via another pathway, and that is an issue which can sometimes be addressed. It can be addressed by looking at multiple genes. So you might have one gene which affects, say, vitamin D levels by one mechanism, another gene which affects vitamin D levels by another mechanism. If you look at the effect of both those genes on your outcome, and if they're both related to your outcome, that suggests that vitamin D is probably important and it's unlikely to be explained by pleiotropy, particularly if you have lots and lots of genes which are all showing the same effects. And an example of that is this nice study on LDL cholesterol and heart disease risk. So in this study, they used 9 different SNPs from 6 genes, all affecting LDL cholesterol. When they calculated the effect of LDL cholesterol on heart disease risk based on the effect of each gene on LDL cholesterol and each gene on heart disease risk, they found that each gene was giving you the same answer, basically. So it sort of rules out the effect of pleiotropy. Another way that you can do this is to do a kind of gene-environment interaction as a check. So in the example of alcohol, if I stratify by alcohol, well, here I've stratified by males versus females, but if you were to stratify by alcohol, you'd probably see the same thing. If there's no alcohol present, as in the females, you don't get any effect of the genotype. But if alcohol is present in the population, then you get an effect of the genotype on outcome. The problem with stratifying by an exposure is that then you're getting into the realms of confounding again. So had I stratified by smoking, because smoking tends to associate with alcohol, you might see a similar sort of effect. So that's something to be aware of. If you're using a gene where you know very well the biology of that gene, it's not so much of an issue again. So as I said, it's not protected from confounding to the same extent. So I've talked about low power, about pleiotropy, population stratification. It used to be that there was a lack of variance for the exposure of interest, but that's less so now due to GWAS. So there's lots, you know, if you can look for, if you're interested in vitamin E, you can probably find a GWAS study which has related genetic variance to vitamin E levels, and you could use those variants to say, does vitamin E affect heart disease risk? Obviously, there may be an issue with complexity of interpretation, and I won't go into that now, but that depends on individual examples. And I just wanted to finish by saying that hopefully you're convinced about the way that Mendelian randomisation can be used and is being used, and this is quite a nice success story for MR, not so much a success story for HDL cholesterol, but really, for many years, HDL cholesterol has been thought to be high HDL cholesterol has been thought to protect against heart disease risk. And obviously, drug companies have been designing drugs to target, to increase HDL cholesterol. Trials of these drugs have shown that the drugs have absolutely no effect on coronary heart disease risk. And this nice Mendelian randomization study, which used genetic variants which affect HDL cholesterol, showed that there was absolutely no effect of these genetic variants on heart disease risk. So in terms of alcohol, that's not good, because when we published this study on alcohol intake and blood pressure, we could say, well, you know, alcohol increases your blood pressure, but it also increases your HDL cholesterol, and HDL cholesterol is thought to be good for heart disease risk, so we don't actually know the overall effect of alcohol on heart disease risk. You know, in balance, it might have no effect. But now, I guess it's not good news for heart disease risk and alcohol. Okay, so I'd just like to conclude that Mendelian randomization can provide more reliable evidence of causal effects of modifiable exposures. So when we use Mendelian randomization, we're not interested in genetic engineering or targeting populations according to genotypes. What we're interested in is what they tell us about modifiable exposures and which ones can we try and reduce to reduce our disease risk. What we know is that generally we need large sample sizes. Sometimes if you haven't got large sample sizes or if you have multiple variants, these can increase your power anyway. And as I said, we're not trying to practice personalized medicine. We're trying to find things which will be generalizable to whole populations. So obviously I'd like to acknowledge George Davies-Smith, who's done an awful lot of work in this area, and Shah Ibrahim, who wrote lots of the initial review papers with him. Lena Chen, who's my PhD student who did the work on blood pressure and alcohol, and Roger Harbord, who was the statistician working on that study. So thank you.